All right, good morning, everyone. I think we'll get started. My name is Clarence Wong. I'm the Director of Division of Gastroenterology, and I'm happy to moderate this round for Dr. Kassam today, who's away. So before we begin, I would like to respectfully acknowledge that we're located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Côte Sioux, Iroquois, Dene, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So it's my pleasure to introduce our speaker today in the new professor season rounds. So Dr. Frank Hoentjen is a gastroenterologist and he's a professor of medicine in the Division of Gastroenterology in the Department of Medicine at the University of Alberta. He is the director of the Inflammatory Bowel Unit and also the co-director of the Gastroenterology Clinical Trials Unit, GILDER, at the UAB. Dr. Hoentjen is the co-chair of the Scientific and Medical Advisory Council for the Crohn's and Colitis Canada. And he's also specializes in real-world evidence on biologics and prevention of colorectal cancer and dysplasia in patients with inflammatory bowel disease. So it's my pleasure to introduce Dr. Hoentjen.
Thank you, Clarence, and it's a great pleasure to be able to bug you with inflammatory bowel disease for the next hour. And I hope everybody cooled off after last evening's storm. So let's get started. These are my disclosures, and these are the objectives for the next hour. So we're going to talk about colon cancer and inflammatory bowel disease. And I'm going to talk to you about risk stratification, tools, and therapy. First of all, I'm going to give you a little bit of background on inflammatory bowel disease. And just to give you a little bit of a better feeling, you probably think we already know this slide. But in general, as we probably all of you know, ulcerative colitis is a chronic inflammatory condition that comes with superficial inflammation, always limited to the colon. The other part is Crohn's disease, which is more a transmural inflammation. It can also affect the small bowel, and due to its transmural appearance, we see frequently complications such as abscesses, fistula tracts, requiring surgery. Couple of things that you see here on the right, the pathogenesis, we still don't fully understand it, which always amazes me, like how much research is put into this field worldwide. And we found a gene that associates with Crohn's disease in the year 2000, the NOT2 gene. And at that time, everybody felt like we're on a track to solve this disease. We're 25 years down the road. We have over 300 genes associated with IBD, and we still don't understand it. We do know that immunology is involved, the microbiome, and more we become aware that environmental factors such as diet plays a really important role. So the fact still is we cannot cure Crohn's disease and ulcerative colitis, and that means that most patients need maintenance therapy to maintain remission throughout life. And so if we look at the epidemiology, you can understand if we cannot cure this disease, and we continue to diagnose new people with IBD, the numbers will keep on going up. And we know in the Western world, the incidence has been rising and rising for many decades. We finally get to a plateau now in the Western world, but the prevalence will keep on going up. And you see here a study that Gil Kaplan coordinated from Calgary, looking at the nationwide incidence and prevalence. And then you see that around this time in adult people, we see that 1 out of 100 Canadians has IBD, and that number will continue to go up. And so we expect in 10 years to have 470,000 people with IBD living in Canada. So those are enormous numbers. We also try to get more granular data on the Edmonton zone. And this is work that Jared Cooper, one of our advanced fellows, did. And Gil Kaplan, again in Calgary, helped us with this project, where we tried to get all the numbers. And when you see here, let me pull up the next one. You can see the number of IBD patients in the Edmonton zone. And then if you look in the year 2002, you see that that number is around 2,500. This year, we estimate we have 14,400 patients, and that number will continue to go up. So those are really enormous numbers. What does that mean for our healthcare that we provide? You see here the numbers for outpatient encounters for IBD patients in our zone. And then you see here at the bottom, you see that that starts around like 30,000 encounters per year for our zone. And that number went up to currently 200,000. So you can imagine what that does for the healthcare system, healthcare providers. So if you see IBD physicians with panic in their eyes walking in the hallway, be gentle to them. So those are the numbers. So how do we treat it? So this is a list of what we used to do in the past. Don't try this at home. This is really like nothing is evidence-based, and it can be even dangerous. So if you see that tool on the right bottom corner, I hope nobody has that at home anymore. So luckily we moved on. In the last 20 years, a lot has changed for therapies. You see in this slide, kind of the way we thought about IBD therapies roughly 10 years ago. At that time, we figured in mild disease, you would start with 5-ASA, and step up would be oral steroids or topical steroids. And then the next step would typically be MGR or methotrexate. And then finally, because we only had 1 or 2 biologics, we would step up to a biologic just before surgery. I think nowadays, the landscape has really changed. So what we try to do nowadays is move on much faster to an advanced therapy like a biologic, because we know the rate of surgery goes down dramatically if you hit people early with a biologic. And we typically skip the steps of conventional immunosuppression. I talked about panic in the eyes of IBD physicians. Sometimes you may also see panic in the eyes of residents. When I did my residency, it was quite easy. Here on the left graph, like you see, we had Remicade and then Humira entered, and it was pretty straightforward. And then I was lucky enough to go through, I would call it an evolution of therapies that were added. But you see, especially the last 5 years, the number of therapies we added is enormous. And so that takes a lot more expertise, experience to understand how to apply these drugs, when, and how to optimize them. So the field is is quickly changing, and in the next few years there's a lot more coming as well. So this is probably in 5 years we will call this a simplified slide. My confession is I never wanted to do inflammatory bowel disease. I dreaded immunology. I dreaded the microbiome. Probably in retrospect because I just didn't understand it. So what I did in the first year of medical school, I just decided I want to do some research, and I called my first choice. The Department of Rheumatology never picked up their phone, so I literally called my second choice, and that was GI. They picked up the phone and they said, a bit surprised, sure. They sent me down an obscure basement, and I started doing work on a gut hormone. It's called PYY. And at that time, it was pretty novel in the late 90s. Published 2 articles on gallbladder contraction and gastric acid secretion in healthy subjects. This is not earth-shattering research. Believe me, it's not. But I couldn't help smiling when I saw my name cited in some Nature publications, because what happened was in 2006, they figured out that this hormone was involved in satiety. So it plays an important role in obesity nowadays. So when I tell you that I never wanted to do IBD, my mentor at that time told me, Frank, you're going to go to Chapel Hill, North Carolina, and do IBD research. I stepped out of his office in 5 minutes, and I shook my head and I just let it happen. And so at the end of the day, I spent almost 3 years working on my PhD program in Chapel Hill. And it was a fantastic time. I had also fantastic mentors there. The guy on the right you may recognize, Leo, he was there until 2003. until he got recruited by a guy named Richard Fedoruk, and he suddenly left for Edmonton. Christian Jobin was a fantastic basic science researcher who's actually Canadian in Florida right now, very successful. And Bel, for starter, is very special. Bel is an amazing mentor. He was trained as a rheumatologist in the 1970s, figured that some of his patients actually had diarrhea but benefited from antibiotics, and finally developed the hypothesis maybe the microbiome is involved in IBD, and he switched to that. This was the 70s and 80s. So Belfour, it's public knowledge that Belfour has Crohn's disease himself. And he always told me, Frank, I'm not going to stop until I have solved this disease. So this is his lab. This is where you see me, still happy and smiling. And Belfour kept the word, and he continued. And I met him for a coffee for Christmas last year. He looks a bit older. He's in his late 70s now. And when I asked him whether he's still working, he was quite insulted, and he is still working full time because we all know why. And so here you see I worked a lot on animal models, IELTA knockout mice, HLA-B27 transgenic rats, and these animals develop spontaneous colitis. When you derive them germ-free, no microbiome at all, they will not develop colitis. So that gives a great model to introduce single bacterial strains and see whether they're beneficial or harmful. So that's what I did for almost 3 years. And then my mentor in the Netherlands became the head of department in Amsterdam and said, Frank, you have to come home now to start your residency, which I did. This is the hub I used to get to work, the central station in Amsterdam. And when you bike in the Netherlands, always remember where you park your bicycle. All right. So that's a little bit of background on IBD. And now we're going to switch gears a little bit to colon cancer. Burrow Crohn was the one who gave his name to the disease we're talking about today. And he published this article in the late 1920s. And he already recognized at that time that he had a patient with a malignant degeneration of a polyp in a patient with ulcerative colitis. And he recognized that this polyp progressed to colon cancer in one of his patients. And so this was 1920s, and this was probably the first scientific evidence that yes, there is a role, there's an increased risk of colon cancer in these patients. It was until 2001, until James Eden in the UK came out with this publication and showed that the risk of colon cancer is dramatically increased. And you see here numbers up to 18% colon cancer risk lifetime if you have colonic IBD. I think nowadays we know that this is definitely an overestimate. There were some flaws in this research, but we still recognize that this risk is definitely increased in most of our patients. And why is that? We do believe that the inflammation plays a really important role. And we do think one of these cascades probably plays a role. We typically see low-grade dysplasia on the colon progressing to high-grade dysplasia and eventually colon cancer if we don't do anything. There's a lot more to this. So this is kind of a simplified version. We can talk for hours about just the basic science behind this, but this is probably giving you a reasonable picture why this inflammation drives carcinogenesis. We did one study already many years ago where we tried a prospective cohort of patients with ulcerative colitis who had shown to have low-grade dysplasia of their colon. And then we tried to look for bacterial oncotraits, and those are basically bacterial products supposed to be involved in the carcinogenesis. And we did find that there were certain oncotraits that were accelerating carcinogenesis, but we saw also ones that were associated with beneficial effects. So this research showed that there's definitely a role for the microbiome in the carcinogenesis, but it's still quite a big black box, especially in IBD. We don't fully understand yet how that interaction works. So we work in clinical practice. We work more with the clinical risk stratification because probably the bigger question is like, can we predict who's going to develop colon cancer? We cannot really predict, but we can identify a number of factors that are involved. Here you see some research that we did. 4,000 patients with IBD and a history of low-grade dysplasia of their colon. And we did find that the subsequent risk of colon cancer was quite high. It was up to 14% after 15 years. If you include high-grade dysplasia, then we see that that risk goes even further up. So this is a very useful tool. And of course, there are many more risk factors that I will show you in a minute. Can we also predict who is at lower risk? We actually can, and together with my good friend Bas Oldenburg in the Netherlands, we set up a study where we hypothesized that if you have a perfect colonoscopy, no inflammation, no polyps, and no cancer, and you reach the cecum with good bowel prep, and you do that twice in a row, your risk of colon cancer is actually 0 for the next 5 years. And we showed that in over 800 patients. You can see that here by the gray line, the cancer-free survival over 10 years, you see here, it's a straight line. We saw 0 colorectal cancer in 800 patients. So, of course, this doesn't apply to all of our patients, but at least it's given us a little bit of a tool how to risk stratify. I finally had two PhD students working on a systematic review and meta-analysis. They still wake up at night with nightmares and drenched in sweat. You can see here they screened almost 11,000 articles, but they did really well. And so this got published, and you can see here on the right, you see risk factors for colon cancer. Here's that low-grade dysplasia I talked about. Extensive disease is, of course, a risk factor because the more colon is involved, the higher your risk of colon cancer. And then I think an important one is primary sclerosing cholangitis. 70% of these patients also have IBD. And this is a bile duct disease that puts you up for a much higher risk of colon cancer. On the left, you can see the protective factors. Of course, there's medication, not necessarily because it's chemoprotective, but we do believe that if you treat the inflammation well, the risk of colon cancer comes down. So we have guidelines in place, and probably every society has their own guidelines. In North America, we typically use the AGA guidelines, and you can see here they were written by Sanjay Murthy in Ottawa, published in 2021. Probably most of us will use these guidelines, and you can see here that risk stratification, if patients are at higher risk for colon cancer, they will be screened yearly. And here you can see that PSC that we talked about, moderate to severe inflammation, and a history of invisible dysplasia that we cannot see on colonoscopy. There's also an intermediate group to be scoped every 2 to 3 years. And those are the people with more mild inflammation, scarring of their colon, or here's that low-grade dysplasia within 5 years. And then, of course, there's the low-risk group. And you can see here those 2 consecutive colonoscopies without any abnormalities are part of the guidelines now. So this is useful, but you can recognize that this is not very specific, and it doesn't really quantify your risk of colon cancer. And as you probably all know, our patients dread the colonoscopy. Even more, they dread the prep that comes with it. But we all have guidelines in place. And so you wonder, like, we hardly have any evidence for these guidelines. And that's almost a philosophical question. We have all of these screening programs, and I think the best known one without any evidence to be implemented is a screening for breast cancer. It was implemented, but like there was 0 evidence to support it. So how do we actually generate that evidence? You would say we cannot do that. But if I would tell you parachute will be life-saving, you would all agree with me. Has the randomized control been done? Actually, it has been. So this is a trial that was done, and the investigators recruited people who will board an aircraft, and the participants will be randomized to either a parachute or an empty backpack, and they didn't know which one they would be allocated to. The non-participants were controls, and you can see here in the next slide the results. You can see that the primary endpoint of this trial was death or major injury. And this was actually 0% for either a parachute or an empty backpack. But once the investigators looked at the confounders, they saw that the non-participants were at over 9 kilometers altitude, while the participants were at an altitude of 0.6 meters. So this research, you may know the Christmas edition of the British Medical Journal. They do this every year with like research that makes you smile. But it does bring up a point like how hard it is to generate evidence for our screening programs.
I don't think that data would be wrong because airplane accident is so low. Whether you wear a parachute or not a parachute, the outcome probably much different.
Yeah. No, for sure. Yeah. If we look at the general population screening for colon cancer, then actually we are quite lucky that some countries were a bit behind the curve with implementing their screening programs. And this is mainly from Northern Europe, where around the year 2008, 2009, they started implementing screening programs. And so the researchers here were just in time to recruit patients to either go without regular screening or get one screening colonoscopy. They recruited 85,000 participants. And when you look here on the right, you see that mortality for colon cancer was not different between the two groups in 85,000 participants. When you look on the left, you see that there was a slightly reduced risk of colon cancer in the people who underwent screening. So there is a signal here that the screening is actually working in the general population, but the signal is quite limited. So before I show you the latest IBD guidelines, here's one prediction model that we tried to design to get our predictions more accurate. Which IBD patients are at higher risk for colon cancer? And basically what we did is almost 4,000 patients in 6 different cohorts worldwide, and we used that to build a predictive model. And it's so complicated that I hardly understand it myself. We had a few methodologists to really design this tool. But at the end of the day, it gave us a model that quite accurately predicted and quantified the colon cancer risk in 5 or 10 years. There's a UK group that took this tool, and with permission, they created a digital calculator. And so you see here on the left now, you can go to this website and you can fill out a bunch of characteristics about your patient, and it will spit out a number for the next 5 years what your risk is of colon cancer or high-grade dysplasia. So this is a really useful tool, and the British Society of Gastroenterology just published their latest updated guidelines on colon cancer screening. It came out 2 months ago. And what is nice is you will see all of these clinical risk factors that we just talked about to quantify patients, whether they're at moderate, large, or small risk. But you can also see that they build in more a risk stratification in terms of numbers. And so they used our model to really build that into the guideline. So you can not only screen by risk factor, but you can also screen by simply the number that this calculator spits out. And that is very helpful, I think, also to talk to your patients and make it really real, that risk. What is also nice, you can see here the low population, the low risk group. You can leave the surveillance program and you can go back to the general population. So that is also a new feature that is really important. And I think we all recognize that some of our patients will never develop colon cancer, but we cannot promise them that it's going to happen. But at least here you have a pathway towards out of that screening program. So how do we do this screening? You can see here a normal colon. But we also recognize that a colon can be inflamed in inflammatory bowel disease. You see some erosions here, some granularity on this picture in the colon. And of course, at times we see much worse inflammation than that. You can see here this white, that's all ulceration, and you can recognize that the colon is already narrowed here. You can take it a step further, and here you can see a completely scarred, narrowed, strictured colon. And so if you do your surveillance, it can be pretty challenging to find any flat dysplastic lesion here. And so that's the biggest challenge for us in the field of IBD, to really recognize the polyps that we need to take out. So how do we detect polyps, and how do we actually treat them? I'm sure you guys can all see the polyp here. You don't have to be an experienced gastroenterologist. And if you're unsure whether you see it, it becomes more obvious when you lift some saline, you lift it with saline, and you inject some ink there. And then with a hot snare, you can basically resect it. So this is pretty standard for most gastroenterologists. We know that, like, from what a polyp will look like, we can recognize the risk of it being colon cancer. You see on the left here, this is a pretty benign pedunculated polyp. In the middle, you see a more lateral spreading flat lesion, which is at much higher risk to become colon cancer. And on the right, you see already that central depression in this polyp, and this turned out to be colon cancer in an early stage. So just looking at the polyp already help you defining the risk of cancer or high-grade dysplasia during your colonoscopy before you get the histology back. So in terms of detection, basically the old-fashioned way of detecting polyps was simply high-definition white light. So that's a regular colonoscopy. Probably 10 years ago, a lot of evidence came to light that if you spray with dye in the colon, you can actually easier identify especially flat lesions. And we call that dye spray chromoendoscopy. You can see here an example where probably this polyp is a bit harder to detect, but once you spray your dye, you will see that you can see the borders more clearly. And here you see another example where that polyp becomes more obvious to spot once you have sprayed your dye. The downside is this dye spray, it's messy and it takes a lot of time because basically the way we do this is, you can see here in the middle of this slide, you go in with your scope, and once you withdraw per segment, you spray the dye, and then you go back in and inspect that segment. So basically you double inspect every single segment of your colon. So then you can understand that it takes a lot more time. And we also know more time spent in the colon will mean a higher polyp detection rate. So is the superiority of this chromoendoscopy maybe simply due to the fact that we spend more time in the colon rather than simply the dye spray? So I designed a randomized controlled trial with Bas Oldenburg in the Netherlands. And we basically took this dye spray technique and we came up with a control group where we scope our patients, we pretend it's chromoendoscopy, and we go into the cecum, we withdraw per segment, we go back in and inspect, but we don't spray the dye. And that's kind of a control group with similar procedural time, but no dye spray. And then we build in a control group with just regular white light, only a regular diagnostic colonoscopy. We completed this trial during COVID. We included over 700 patients in 4 sites. And basically we published it at the beginning of this calendar year. And you can see here the primary endpoint of colorectal neoplasia, every polyp or cancer that we found. You saw that in the control group, we found that in 10% of scopes. In the chromoendoscopy group, 13%. And when we looked at the predefined non-inferiority margin, there was no specific difference between the 2 groups. So this trial doesn't provide a definitive answer, but at least it gives us an idea that maybe that dye spray is not really the thing that we truly need for polyp detection. So in the last 5 years, the field moved on. We have now something called narrow band imaging. You basically flick a button on your scope and it will use different wavelengths of light. And it will allow us to also see polyps more easily and identify the borders of any polyp. And you can see here an example what that could look like. So this technique called MBI is becoming more mainstay now, also in inflammatory bowel disease. Lisa, who's sitting here in the room, actually run a survey nationwide asking all the IBD physicians in Canada what technique they use now today to screen your patients. And then you see that a lot of physicians already are departing from chromoendoscopy, that dye spray, and using the MBI now. You see 85% have moved towards MBI. So there's definitely a lot of movement there. Once you find your polyp, make sure that you have a second pathologist do a readout. We know that from Barrett's esophagus, where if you revise pathology, you can sometimes get different outcomes, and that means a different prognosis. We took a cohort of 54 patients with high-grade dysplasia of their colon, and we know that's a pretty high risk for subsequent colon cancer, and that risk can go up to 40% lifetime. And so a lot of these patients eventually underwent a colectomy and a permanent ileostomy. Once we asked a blinded pathology panel with expert pathologists in GI, when we asked them to revise these 54 biopsies, we saw that 18 patients were actually downgraded from high-grade dysplasia to low-grade dysplasia. Once we looked at the subsequent risk of cancer, you saw that the blue line is the group that got downgraded, and their colon cancer risk became actually 0. While actually the group in the true confirmed high-grade dysplasia even went up from 18 to 26%. So what comes out of your pathology, don't necessarily immediately believe it, but make sure to revise it because it may alter your strategy. All right, a little sidestep. So in 2010, I did my advanced IBD fellowship at the University of Chicago. Had a wonderful year. My daughter was born here, was born there, I should say. And these were my mentors, Steve Hanauer, David Rubin, and Russ Cohen. They're amazing mentors. They look really smiley and friendly, but they're tough as nails, believe me. It was a very good year, but then eventually I went back to the Netherlands and actually went back to Nijmegen, where I did my medical school originally, and I started there as faculty in 2011. This is what we believe the city looked like in medieval times, and the city is over 2,000 years old, so there is quite some history. And I think the most important historic event in recent times is the accident bombing in the Second World War. So the whole Allied pilots thought they were above Germany, released their bombs, but were not there yet. They were still above Nijmegen in the Netherlands. And so the whole town got destroyed. This is what it would look like nowadays. And I do wanted to make mention of my mentor there, Joost Drent, who moved on to Amsterdam now. But he is the president-elect for the European Gastroenterology Association. And Joost was so engaged with research, you could truly, literally call him at 3 a.m. to talk about a new trial design, and he would literally wake up and talk to you for an hour. If you would call him about an upper GI bleed, he said, Frank, call me back tomorrow morning. So that brings me to a few more slides. We're almost there. Where do we take this? And so these are the future directions that I see that we want to do. And so the problem with doing this type of research is the risk of colon cancer, although it's elevated in our patients, the chance that we're going to find it is still, in absolute terms, pretty low. So how do you design a trial where the event rate is very low? That means you need enormous cohort sizes to do any randomized controlled trial. So I thought we need to go to a high-risk group, and the highest risk group is patients who have IBD and primary sclerosing cholangitis. Now, we work in a liver transplant center, and as an IBD physician, I don't always I'm not always excited about treating liver transplant patients on our wards. It's not my expertise, but there's a lot of PSC patients at our site that we treat. And so if you put those two together, it makes sense that we do more research in this field. So we are really excited to really build a large cohort to really look in these specific patients, to look at the risk of colon cancer, to see whether we can identify low versus high risk in this specific high risk group. And eventually, I hope once we can identify that low risk group, we can tell them to increase the interval between scopes. And imagine if you're 18, you're diagnosed with this disease, and you know that for the rest of your life, you want a yearly colonoscopies. It wouldn't put a smile on your face. And if we can make the 2 years, it would make a big difference for a lot of patients. So we started building a cohort. You can see here that every site I talked to was excited, suggested another site to talk to, and this is the cohort that we have put together now. The first meeting was it was like kindergarten. These are all esteemed researchers, but everybody got so excited and threw in research questions that after an hour, my whole desk was filled up with sticky notes. And I think we've got a plan for the next 10 years to work on a lot of research questions. The second part that I see happening in the next 5 years is AI. So we talked about that narrow band imaging and dye spray. Artificial intelligence is coming. It's in colonoscopies already right now. Most sites do not have it yet, but here at U, we're going to get it within the next few months, and we're going to have 2 theaters equipped with it. It's basically you switch on a button, and then real time, the software will indicate where it sees a polyp, as you can see here. And it gets even better because it doesn't even tell you where it is, but it also tells you the likelihood that it's a dysplastic polyp and whether you should remove it or not. So that is a great development, and it's been shown in trials in the regular screening population that it actually increases your yield of polyp detection. In inflammatory bowel disease, no trial has been done yet. And the difficulty in IBD is a colon is typically scarred, it's inflamed, and we don't always know whether the software will distinguish polyps with that specific background. You can see an example here. This is a colon from an IBD patient. These are all small pseudopolyps. Those are benign, you don't have to remove them. But does AI know that? And that's the big question. And so we're hoping to design a large randomized controlled trial nationwide to compare AI with the current golden standard of NBI. The trial has been designed. We're just looking out for money now. So that brings me to the end of my talk. I haven't done this work alone. I would say the opposite. These are all the graduate students I supervise as primary supervisor in the last almost 15 years. And these are amazing, amazing people who all grew so much during their graduate program and did really amazing work. And I did the math yesterday. 8 of them moved on to become gastroenterologists now or are doing their GI residency. I want to highlight Lisa. You can see her at the right bottom corner. Lisa is an MD who came from the Netherlands. She works here already for 2 years at the U and is hoping to get into her internal medicine residency in the next with the next round. And then finally, I tend to say you can go to work and you can love the work you're doing, but at the end of the day, it's about the people you work with. And this is our amazing IBD group, our IBD physicians and IBD nurses. They do amazing work every single day and so great to work with. A big thank you and a big thank you to the entire division of gastroenterology. Thank you.
Thanks very much, Frank. Excellent overview and presentation. So any questions from the group? Dr. Croker.
So I think one of the biggest challenges we have in regular colon cancer screening is when to stop. And so I feel like that's the same question we have in IBD people. We've been stopping PSC people every year and another 100 people. But when do you, I know we individualize it, but do you have any own personal age rules or?
Yeah, that's a good question. So when do we stop screening? Personally, at the age of 70, I start thinking about it with my patients. And at that age, I really do the risk stratification with my patients. Are you high or low risk? We had multiple negative colonoscopies. And are you fit enough to undergo a scope? And when we put all of that together, some patients are a clear yes, let's do it. And others are more like, let's not do it. And if we're unsure, I typically give them the benefit of the doubt. We do it once, and then we decide, we think about it again 3 to 5 years from there. 75 is for me a pretty solid cutoff where I don't think there's any anticipated benefit anymore, because if you have IBD for your entire life and you hit the age of 75 without any events, it's very unlikely to happen in the next 5 years.
Dr. Ma?
I have two questions. One is, do we know the natural history of IBD associated colon cancer post liver transplant? When you have a different liver and they are under immunosuppression, and typically they also, a lot of them, they're in their 30s when they would have the transplant.
Yeah, so the question is for the virtual audience, what is the risk of colon cancer after liver transplant? It's a tough one to really generate evidence. Number one, of course, the cohort size is pretty small. Number two, these patients get all immunosuppression for their liver transplant, so that might be actually protective because it typically treats ulcerative colitis or Crohn's. And then the most severe cases with inflammation may end up getting a colectomy, so they can never develop colon cancer in the first place. So I'm not aware of any solid evidence. We have one study from the Netherlands where actually they showed that a colectomy eventually may be protective long-term, but there's the obvious confounder. If you don't have a big part of your colon left, then of course that number comes down automatically. I think it's a really good one to do, and we're working on a post-liver transplant cohort with IBD right now. We have 5 sites on board, and this is one of the questions that we can probably try to answer.
Second question is, we see more women with PSC now, and do they have the same natural history as men with PSC and colitis?
Yeah, so the question is whether there's any gender difference in colon cancer risk in people with PSC. I think in the IBD population and the general population, we see that males are slightly higher risk. I'm not aware in IBD and PSC whether there's any gender difference there. In terms of like your risk of developing IBD, we don't really see big differences between males and females. But for colon cancer, it's a good question in that specific cohort whether there's any relevant differences. I'm not aware of any. Yeah.
The reason why is obviously screening, and colectomy in young women is much more problematic in terms of psychosocial. There's quality of life and that.
Yeah, no, absolutely. We do know, of course, we see a lot of colectomies in our IBD patients. Generally speaking, actually, if you look at the quality of life picture, actually a lot of my patients do better afterwards, and they tell me I should have done this many years ago. But that's mainly in patients with like inflammatory disease activity. A lifelong ileostomy is, of course, a challenge. Some of our patients move on to get an ileoanal pouch. But again, that will impact fertility rates. And we also have some circumstantial evidence that people with IBD and PSC may have worse outcomes after ileoanal pouch construction. So that's why our surgeons are slightly hesitant to plug the pouch in those patients.
So Frank, maybe I can ask you a question. So there's been really interesting research on early colon cancer in non-IBD patients, right? And obviously that linked back to your discussion about the microbiome, E. coli, Colobactin. So it's fascinating to me that group is not an IBD group, and it was presented as colon cancer. So what do you think about that?
Yeah, so there's definitely a group of patients, and I relate it back to IBD. I think there's definitely a group of patients who have undiagnosed IBD and sometimes even get their first colonoscopy done and then are diagnosed with end-IBD, new onset, and colon cancer. We start screening our patients for colon cancer after 8 to 10 years of disease, but we know that we miss colon cancer by 15 to 20%. That happens before those 8 years of disease. You can, of course, start screening earlier, but then you probably overdo it. And so that's why we use that cutoff of 8 years. But there's definitely a group of usually more mild disease that probably walk around with undiagnosed IBD for a longer time and therefore develop colon cancer. Yes.
Thanks, Frank. My question's not directly related to your talk, but on your slide about the protective effects with smoking and statins, and I'm also aware I read something that Karen Batson's doing SGLT2s in IBD. What is the role of these conventionally non-GI drugs? What's the future of them in IBD?
Yeah, that's a good question. So what can we do for chemoprotection for colon cancer with medication? Of course, the ones that stand out are the statins and the so-called NSAIDs. Obviously, NSAIDs we're quite careful with in IBD patients because they may trigger a new flare. So we typically try to discourage that in our patients. Statin, I don't think there are truly strong signals that they really prevent colon cancer in IBD, and really the mainstay is still like the inflammatory effect. And so that's why you see here the 5-ASA and the Indiran. The newer agent like the biologics, it's too new to really have solid evidence yet whether it prevents colon cancer, but my bet is we're going to find that as well. But so for conventional strategies, there's not a lot out there, unfortunately.
And is there any research related to the nicotine side of things?
Yeah, nicotine in IBD. So for colon cancer, not that I'm aware of specifically in the field of IBD, but we do know it's a protective factor for ulcerative colitis. Ulcerative colitis, we tend to call it a disease of ex-smokers, where typically people are protected by cigarette smoke. And then after stopping it, they develop bloody diarrhea and they are diagnosed with ulcerative colitis. What specifically it is in cigarette smoke that triggers this, we are not sure. I've been told that there are over 1,000 chemical components in cigarette smoke. And there are systems researchers set up with cigarette smoke going through pipes, hitting colons. Nothing is out there yet that really identified that one protective factor. But so again, likely it's probably the protective effect for ulcerative colitis and thus the anti-inflammatory effect that make cigarette smoke protective for colon cancer.
So Frank, just 2 quick ones online. So one was just quickly, why do PSC patients have a higher risk of colon cancer? What do you think?
Yeah, so why do people with IBD and PSC develop colon cancer? I wish I know. There's so much unknown about this disease. We see in these patients typically the inflammation that is more right-sided in the colon other than regular IBD. We see that there is also a higher risk of colon cancer in that right colon, this specific subgroup. Why it is, it's really hard to tell. I think for sure it's ongoing inflammation, because we do know a lot of these patients have that smoldering inflammation without any symptoms. It's a milder phenotype, but that puts them also at risk of walking around with untreated disease longer because they don't have any symptoms. Number 2, there must be a microbiome component to it, which probably explains why there's right-sided inflammation and right-sided colon cancer risk. And I'm sure there must be a genetic component as well. We haven't identified that factor, but I'm pretty sure it must be a combination of these 3 that will explain this risk. If I have found it, I will win a Nobel Prize and I might quit my job. Yeah.
So Sanders on, and Sanders asking, Frank, he says, do you think there's going to be a role for FIT in IBD screening? Maybe some of that low risk group that you pointed out?
Is there a role for FIT screening in IBD? No, no, no. every IBD patient will have a positive fit test because of the inflammation or even their inflammation that's in remission. The fit test is 90% positive in IBD patients. So I generally tell family physicians, do not do fit testing. It's always positive.
And actually, it's a fascinating thing. I was just looking at our cohort from Scope. There's always a percentage every year fit positive that is asymptomatic IBD patients. There's always a cohort that comes from that. So it's a fascinating. And last question, the other.
Right, that was an excellent presentation, thank you. So just a brief comment from for PSC, these patients definitely are so peculiar. They also have, as we know, a really high risk of hepatobiliary malignancy, 20% in 10 to 20 years of follow-up. But a couple of comments. I think in your registry, what I think is fantastic, it will be really nice also to see what happened with those patients who have PSC and overlapping features of autoimmune hepatitis, because it seems like they behave significantly different. And I think the risk of colorectal malignancy is also completely different. And the second is, I think it will be very nice to have evidence of AI, specifically, not only for the colonoscopy findings, but for the pathology findings, to see how those patients who are categorized as low dysplasia, the concordance, and maybe that can actually improve detection. So,
no, those are really good points. And I think for the virtual audience, comment one is pathology and AI. If you ask AI, it will tell you that the first ones out of a job are radiologists and pathologists, because that's clearly like a field where it's very protocolized and AI can really help there. And I think there are good studies out there that show that like AI in pathology performs better than humans in specific scenarios. And for your other comment about PSC and an overlap syndrome with inflammatory autoimmune disease, for sure, I'm confident that small duct PSC versus large duct PSC versus the overlap with autoimmune hepatitis will definitely have different disease courses. I think the signal is so weak that you need a large cohort to really identify those trends. And that's actually one of the things, although I'm more interested in the luminal side in this registry, but I'm hopeful that you will help us sorting out the hepatology part.
Right. So thanks for attending. Thanks for listening online. Excellent presentation. Thank you.